Great. Thank you. Cool. So Ash and I, our topic we chose was Parkinson's disease. So for first, Ash, you want to go into the next slide?
Yep, sorry, it didn't click. There you go.
Perfect. So Parkinson's disease, or with short form is PD, is a progressive nervous system disorder that affects movement. Symptoms usually start gradually and then sometimes starting with like a barely noticeable tremor in just one hand. And then tremors are very common, but the disorder also commonly causes stiffness or slowing of movement. There are four main symptoms of Parkinson's. One is tremor, or trembling in the hands, arms, legs, jaw, or head. Second is stiffness of the limbs and trunk, slowness of movement, and an impaired balance and coordination, sometimes leading to falls. Other symptoms may also include depression and other emotional changes, difficulty swallowing, chewing, and speaking, urinary problems or I can't speak, constipation, skin problems, and also sleep disruptions. So by 2020, which is this year, it was predicted that nearly 1 million are living in the US with PD. Approximately 60,000 Americans are diagnosed with PD each year, and then more than 10 million individuals worldwide are living with PD. The incidence of PD increases with age, but an estimated 4% of individuals with PD are diagnosed before the age of 50. And then men are 1.5 times more likely to have PD than women. And if you look towards the right of the slide, there's this image of what's called the Parkinson's Foundation Parkinson's Prevalence Project, also known as the P4. So basically what they did is they decided to do a graphic representation of the results of what's called the P4 paper applied to the population structure of individual states in the US. And those individuals they looked at were 45 years and older, and comparing it to the 2016 state level US Census data. The result was that the states with larger populations and or larger numbers of elderly will have higher estimated numbers with PD. This represents an improved estimate of over previous attempts, but is by no means definitive. The authors of the P4 paper noted that the results was likely represents the minimum number of people with PD in the US, and the number may actually be much higher. Therefore, the Parkinson's Foundation is working to help support more federal efforts into creating a comprehensive national measure for those individuals living with PD. And if you go onto their project, it's actually an interactive map, and you can click on the states and see more details of this project. So to be diagnosed with PD, there's actually a number of disorders that can cause symptoms that are similar to those of Parkinson's disease. Individuals with Parkinson's-like symptoms that result from other causes are sometimes said to have Parkinsonism, which refers to the clinical manifestations but makes no specific inference regarding the pathophysiology or etiology of the condition. Then while these disorders initially may be misdiagnosed as Parkinson's, certain medical tests as well as response to drug treatment may help distinguish them from Parkinson's. Diagnosis is usually based on a person's medical history and a neurological examination, and improvement after initiating medication is another important hallmark of PD. So other impacts of Parkinson's, depression is estimated that at least 50% of those diagnosed with PD will experience some sort of depression during their illness. Depression is actually a part of PD itself, since the changes in the chemistry of the brain in those areas that produce dopamine, norepinephrine, and serotonin, those chemicals are affected in PD and also involved in regulating mood, energy, motivation, appetite, and sleep. Chronic fatigue. Fatigue is very common early in the course of PD, but it can occur at any point and stage of PD, and it can even happen with either movement symptoms are either mild or severe. It is sometimes confused with other symptoms that can make a person sleepy or tired, like sleep disturbances or pain, but fatigue is also a symptom of depression as well, but a person can be fatigued without being depressed. And stress can also make fatigue worse. There's two types of fatigue that PD individuals experience. One is physical fatigue, which is the feeling of deeply tired or weary may worsen with off fluctuations. And then there's mental fatigue, meaning mental tiredness that makes it difficult to concentrate. Anxiety, as many as 2 out of 5 people with PD have experienced one of these forms, which is generalized anxiety disorder, anxiety attacks, social avoidance, or obsessive compulsive disorder, and is a common non-motor symptom of PD. Parkinson's pain, Parkinson's disease pain is divided into 5 categories, and pain is actually ranked high by patients as like a troublesome symptom in all stages of disease. It is, the 5 categories are musculoskeletal, neuropathic, radicular, dystonic, I can't say this word, but akathisia, akathisia, which is causes the feeling of restlessness or inability to be still, and then central pain. And then for individuals with PD, sleep becomes even more important as the body needs more energy and time to restore and repair itself. So the brain changes that are part of PD can also cause sleep difficulties, because some individuals that have problems sleeping even before symptoms can even develop and before PD can diagnose. And last one is apathy. Apathy plays a big role because it describes a lack of interest, enthusiasm, and motivation. But as many as 2 out of 5 people with PD will, it interferes with the effective management of PD symptoms, since apathetic people are less inclined to do things like exercise and follow their medication schedules. Next slide. Perfect. So there's a couple of medical and psychological assessments that can assess PD. There's the cognitive test, obviously, that will test for cognitive decline. Example I have up here, the WAIS, the DCAPS, FAS, the WISC, WCST, and the MMSE, which all can also be found in like a neuropsychological evaluation. Mood assessments such as the Beck's, like the Beck's Depression Inventory, the Beck's Anxiety Inventory. There's also the Hospital Anxiety Depression Scale, PANIS, the Situational Fatigue, and they also have one for apathy that they like to use, which is called the Apathy Evaluation Scale. For movement assessment, since motor assessment of Parkinson's disease can be divided into clinometrics assessments of balance, posture, arm, and hand function, and also gait or walking. For example, the Berg Balance Scale is used very commonly with individuals with PD. And then the most common assessment for functionality, the ability to function in PD individuals, is the Schwab and England scale, which is called the Activities of Daily Living, and is used to provide a single estimate of the individual's ability to function. Pain scales, there's really not a actual like assessment, but what I've been found in the research is an actual physical scale, sliding scale that you move up and down a value. So it's like a visual analog scale, or what they call it like a painometer. There is in the literature a scale that got published back in 2017. It was called the King PD Pain Scale. However, and it was invented because there was not one validated specific pain scale for individuals with Parkinson's. However, it has not been widely validated yet, so a lot of medical centers won't be using that, but there are other pain measurements that can be used. And then assessing quality of life, so that's there's many universal questionnaires for that. The sickness impact profile, the short form health status survey, those are the most popular ones in Parkinson's disease. There are also specific questionnaires, such as the Parkinson's disease questionnaire and the Parkinson's disease quality of life questionnaire, that can also be used if we're more specific for individuals with PD.
Okay. So when it comes to treatment, there are general guidelines that doctors use to choose a treatment regimen. But that being said, each person with Parkinson's disease must be individually evaluated to determine which drug or combination of medications is best for them. And then also assessing a patient's quality of life is helpful in allowing clinicians to determine the effectiveness of a treatment. The primary goal of Parkinson's disease management focuses on treating the symptoms that have a significant impact on the patient's quality of life. And as we can see, there are a lot of different treatments that go into Parkinson's disease. Of course, the most ideal one is this multidisciplinary team care model where we can use integrated team members to help the patient from many different angles. So I'm going to generally go over these treatments because you could just go deep into this forever. So when it comes to the drug treatments, a lot of the drug treatments are aimed at temporarily replenishing the dopamine or mimicking the action of dopamine. The most common drug form is levodopa. And that levodopa is synthesized into the brain as dopamine. It's the most important first-line drug for the management of Parkinson's disease. What it does, though, is it causes a lot of nausea. So most patients that are on levodopa are also on carbidopa, which is a levodopa enhancer. And people will go on to levodopa for the dopamine enhancement, but it has a side effect of causing dyskinesia. So this is a long-term motor complication, and it compromises the success of levodopa therapy. It usually starts to come in about 3 to 5 years after starting drug treatments. And then you just want to make sure that you're also assessing the patient's emotional well-being, cognition, and communication domains when it comes to levodopa. There was a study that had shown that it kind of induces complications there. So that is the main drug treatment. There are a multitude. And then deep brain stimulation is also used to treat Parkinson's disease. A lot of times deep brain stimulation comes in because the levodopa or the dopamine synthesizing medication is causing disabling tremors, which can be debilitating and have a large impact on the patient's quality of life. Deep brain stimulation is for people who've had Parkinson's disease for at least 4 years and have motor symptoms that aren't adequately controlled with good medication or with medication. The surgery itself costs between $28,000 and $50,000 on average. And good candidates will have an adequate response to the therapy, presence of on-off fluctuations, dyskinesia, impairing quality of life, medication-resistant tremor, and reasonable cognitive function. There are some pretty serious side effects: cognitive impairment, memory deficits, difficulties with speech, disequilibrium, motor and sensory disturbances. And then there's also emotional and psychological side effects associated with deep brain stimulation, such as mania, depression, apathy, laughter, crying, panic, fear, anxiety, and suicidal ideation. So it's really important to screen patients with Parkinson's disease for suicidal ideation before and after surgeries such as deep brain stimulation. And this source right here is a really great option if anybody's interested in finding out a little bit more about deep brain stimulation. Mind-body exercises. These are really great because they're low cost, they're easy to operate, low impact, moderate intensity aerobic exercises that emphasize skeletal muscle stretching and relaxation, physical coordination training, and emphasizes breathing and movement control. The perfect combination of mind and body can have a positive effect on the body and mind rehabilitation of chronic diseases, especially for non-motor symptoms such as depression, stress, pain, cardiovascular disease, and high blood pressure. And as Joanna mentioned, depression is it's very present in patients with Parkinson's disease. At present, a lot of the common forms of physical and mental exercises include health qigong, tai chi, and yoga. Tai Chi, health qigong, and yoga improve motor function, reduce depressive symptoms, and can increase the quality of life for patients. They can rehabilitate the patient's motor function. Yoga has also demonstrated benefits in improving physical well-being, such as more of these motor symptoms, postural instability, and functional mobility. Mindfulness yoga programs have been found to be effective for alleviating psychological distress, decreasing motor symptoms, and improving physical well-being and quality of life. And Tai Chi has found that it can reduce falls for up to 6 months after the treatment has ended. Physical and occupational therapy are also pretty critical. The goals here are to keep the patient moving as well as they can for as long as possible. to improve or hold the symptoms at bay as long as they can. So this can include gait and balance training, resistance training, regular exercise. And it's important to begin these treatments early as to not miss the window of opportunity to address the non-obvious impairments. Increasing physical activity for at least 2.5 hours a week, can show a decline, can slow the decline in quality of life. Multidisciplinary team care, of course, is ideal in treatment because each patient is probably going to need a combination of these treatments. And so you want professionals that are specialized in each field, who can treat the medications, can educate about mood disturbance and how it relates to Parkinson's disease, facilitate skills and improve strategies to cope and adapt, and then provide some emotional support. So here are some of the targets of intervention for health psychologists who have patients with Parkinson's disease. The quality of life is kind of one of the biggest parts because the most frequently identified detriment of quality of life is the presence of depressive symptoms. Researchers also reported that depression was the main factor associated with quality of life and the perception that Parkinson's disease has on the negative impact of functional ability. This lack of dopamine, of course, makes depression and apathy the core symptoms of Parkinson's disease. So we have a lot to work on here with Parkinson's disease patients. When it comes to treating Parkinson's disease patients, it's good to start with catering to the cognitive needs of the patient. So working with the patient on a level where they are literate, providing them documents that meet their literacy levels, speaking a little bit slower, also assessing their understanding along with their adherence by asking them to repeat instructions back to see what they have taken in, assess their health beliefs, what their perception is of their disease and where they're at in the disease, and how involved they feel that they are in the treatment. Of course, also planning for obstacles and identifying barriers. This can be especially apparent for patients who have a harder time accessing healthcare, and also identifying where we can help them when it comes to work barriers, social barriers, and autonomy. This is why identifying social support is pretty important, because the presence of more social support was related with a greater likelihood of remaining employed, and this is another crucial variable for patients for persevering in high satisfaction with life. It seems that social support specifically facilitates the patient's social inclusion and work engagement and the maintenance of their satisfaction with life. And then also focusing on a recovery-oriented approach that can focus on the individual's strengths, resilience, and help them come up with goals that are meaningful to themselves. So when it comes to what we know about Parkinson's disease, I just wanted to kind of highlight some cultural contributions. Of course, we think of James Parkinson, who is from London from the late 17th, early 18th centuries. So he coined the term shaking palsy, and also really thoroughly identified the physical characteristics associated with Parkinson's disease. He did omit the dysfunction in cognition and emotion that we now recognize with shaking palsy. He mentioned in one of his writings that the sense of the intellects remain uninjured, which is wrong, as we know. But he was one of the first to shine a spotlight on the symptoms of resting to tremor, postural instability, slowness of movement, as a characteristic of the disease process. I also wanted to point out that traditional Chinese medicine, Ayurveda, they've described symptoms of Parkinson's disease centuries and millennia before James Parkinson did. So for Chinese documents, the first documentation of the disease was in the Yellow Emperor's Internal Classic from 425 to 221 BC, so significantly earlier. They also have developed forms of treatment that have some evidence that have evidence behind them, such as acupuncture, Tai Chi as mind-body exercises. So also, yes, sorry, going off track a little bit. And then for in India, Ayurvedic medicine was developed and practiced for over 5,000 years. And they also have been treating the disease with a preparation that's derived from Mucuna pruriens. So this is a natural plant, and research in animal models suggests that this plant may be more effective than synthetic L-DOPA in treating Parkinson's symptoms. They also use another botanical called ashwagandha to reduce anxiety with patients that have Parkinson's disease. And they are also the founders of yoga, which is rooted in the Vedic philosophy of ancient India. And the West has really taken this on, adopting the mind-body modality to use for improvements in motor functions and quality of life in patients with Parkinson's disease. There is a large gap in the research. Some of the disparities in care and outcomes in diverse populations are missing. So disparities need to be detected and measured. The reasons might be understood for why there's a disparity, but we also must understand the why. For example, it was found that African Americans were referred to deep brain stimulation surgery at much lower rates than Caucasians. So this disparity has been detected, but we still need research in developing reasoning as to why. There's also a lower minority participation in clinical trials of Parkinson's disease, as well as all fields of medicine, honestly. The Caucasian population participation is about 3 times more likely to participate in clinical trials of Parkinson's disease than those of other race identities. So there is a need for increasing motivation for people of marginalized identities to participate, because we're not including them in clinical trials. And then we also need to include an overview of genetics in diverse Parkinson's disease populations. Genetic studies need to include participants of varying ethnicities, since genetic mutations that contribute to Parkinson's disease vary significantly between populations. So even the discovery of one new genetic mutation that causes Parkinson's disease actually opens a window to understand Parkinson's disease more generally for all populations.
All right, and so lastly, we're going to talk about the ethical issues in regards to Parkinson's disease. A lot of the ethical issues are actually surrounding more of the management of Parkinson's disease. So the first one issue is between novel versus established therapies. So patients often are and should be well informed about novel therapies and may ask and demand them, or they may fail to understand that is still either very much in development, or even if approved, the more traditional approaches are, the advantages to more traditional approaches are more better, and the compared to novel ones, the advantage might be more limited. So as such, there's like a fine line in between being a medical health provider and an obligation to the scientific community, where some patients might feel that they are being a good therapy or treatment might be feeling that they are being it is being withheld from them, and they might go to a different country or somewhere else to get access to that treatment intervention. And that, of course, raises additional ethical concerns, but including the practice of providing unproven therapies as if they were established, as well as the obligation to the scientific and medical communities to balance optimism with realism. The second ethical issue is the medical effects, or medication effects, excuse me. And as Ash has said, there's many side effects to doing medications. One's specifically mentioning is the one involving dopamine, so dopaminergic therapies. Dopaminergic therapies do affect or have a major influence of a person's personality. For dopamine, it influences the personality factors of novelty seeking and to a lesser extent harm avoidance. So this means we have to require very careful weighing of risk and potential benefits of medication or medication treatment. It also affects decision making. So individuals with PD individuals that are on a dopaminergic therapy are impaired of learning from negative outcomes or negative experiences. And also when they go off or on these therapies, there may be a development of biases when determining or making a decision about medical treatment, choosing a treatment, making other risk-associated decisions in their personal private life. And there might well be bias in like this, depending on the status of their medication, and researchers and physicians have to inform patients about this potential bias, especially when especially about like surgeries, and need to keep in mind the potential limitation when consenting patients to procedures, treatments, and or research studies. It also affects a lot of impulsive and compulsive symptoms. So dopaminergic medications used to treat PD can lead to impulsive and compulsive symptoms, and about 6 to 14 of the patients treated with this kind of medication are affected by potentially devastating side effects, which consists of a complex, often like repetition disinhibitory addiction-like behaviors, and include impulse control disorders, what's also called punding, and also so-called dopamine dysregulation syndrome. And these are also associated with changes in reward-related behavior, personality traits, decision-making, and cognition. So the neuropsychiatric side effects of PD are also thus raising questions related to self-autonomy, determinism, and moral agency. The placebo effect. So back also again, novel versus established. When going into these surgical treatments and to testing out these surgical trials, we have to also be careful in regards to the placebo effect and how it has an effect on PD individuals. Again, through the Parkinson's disease are thought to be mediated by the release of dopamine into the striatum and associated with the anticipated electrophysiological changes downstream of the brain. It is important to understanding like the potential power of placebo effect that PD has is that the anticipation of benefit may not only color the patient's subjective responses to therapy, but also has a physiological basis for placebo response, may result in improvement in objective measures conducted by a blind observer. There are also ethical implications of this. Again, PD individuals and families are often well informed about new scientific advances, and particularly about new therapies. So giving, again, the devastating effects of the illness, they are sometimes understandably frustrated if they are not offered immediate access to such novel treatments. However, again, those are many potential risks. They're far from trivial, and the benefits are definitely unproven. So such issues, again, arise with significant questions about the ethical responsibility of the scientific community in presenting these promising findings in a realistic and appropriate cautious fashion. And then next we have is, again, surgical interventions such as DBS. Again, for the advantage of DBS over drug therapy alone lies in improvement of motor complications such as dyskinesia and motor influctuations associated with dopamine medication. So like Ash said, the DBS has a lot of side effects, and many individuals need to be screened, and it's very important for us to screen those individuals. That being said, that means that not many people will be able to have a DBS, or not many other individuals will be able to get DBS surgery. And so because of these potential side effects, because of the selection, is it our ethical responsibility to, again, give them a treatment that may help and solve their problems versus a treatment that may not benefit them and actually more, again, of a side effects and a lot more risks. With DBS, there's also realistic expectation that must be set. Again, patients and caregivers' education is very crucial, and again, individuals research all the time on the internet about what is available. So the education is very important because it's to avoid all non-perfect outcomes as failures. Ideally, specific target symptoms that are aimed to be improved by DBS should be identified together with the patient. Likewise, education of the public with balanced information is important, as like widely publicized, medialized miracle stories contribute to unrealistic expectations in patients and their families. And so health psychologists and physicians should also supply reliable internet sources for information, as many patients and again, their families also now try to search for answers on the internet. The last thing for infrastructure and neurodegenerative disease. So our planet and world, our population is not getting any younger, and it's going to get older as medical tools and treatments and everything advances. So the main question is like, who will be responsible for the exponential growth need for medical care at the end of a long life, in particular during an advanced stage of a neurodegenerative disease? And how are we going to allocate limited resources generated by a workforce that's already shrinking and relative to the percentage of the older retired part of the population? Medical advances with longer survival of patients with PD also will lead to more patients developing challenging non-motor, especially cognitive and neuropsychiatric symptoms as their disease advances. And these patients frequently require both neurological as well as neuropsychiatric care and services that needs to be provided from basically us working force individuals. And that is all. And these are our resources, 2 pages. And you can also check onto the document as well for more information and cool stuff about Parkinson as well.
Thank you for listening.
Thank you. Any questions?